hear myself in both places. Okay, we'll try again. Ready, everybody?
Ready, everybody. Connection, orthodontist and myofunctional therapist. And why does nobody work in collaboration?
You tell me. This is a fight that we have every day. It is so difficult. So you cannot address the structure without addressing the muscle, and you cannot address the muscle without addressing the structure. I always tell my patients that the reason why myofunctional therapy works is because I'm not doing this alone. It's not myofunctional therapy by itself ever, because there is a person attached to the facial muscles and to the teeth. So we can't just look at one thing. Every single time we change something, it's going to change everything else. So working in collaboration is key for our patients to get the best treatment possible out there. So an ENT to look at the airway, an orthodontist to look at the skeletal structure, and a myofunctional therapist to address the muscle. If we miss one of them, the patient will relapse.
I think this is already a very crucial point, which I totally agree with. Like in London or the UK, more and more dentists are actually doing orthodontics. And they're using especially AI technology to generate a treatment plan, for example, with aligners. And in all of this, the function around the teeth is not even slightly even considered. They are just being told you need long life retention versus some other like you would totally agree with me now if I would say your function is your retention.
100%. Your lips and your tongue is the perfect space maintainer or retainer that you can get after orthodontics. Why? If I'm talking to a parent or a patient, I explain that whenever orthodontists move teeth, they need light but constant pressure on the tooth in order for the tooth to move. So whenever somebody's swallowing, that pressure is a little bit stronger if they're swallowing incorrectly, and it's every so often. However, the pressure of your lips and your tongue at rest could impact your occlusion. So just by doing myofunctional therapy, just addressing the muscle function, the muscle tone and strength, we see teeth move. Do I claim that I move teeth? 100% no, but I have seen it happen. So just addressing where your lips supposed to be. Your lips are supposed to be at rest, touching lightly without much tension. Breathing has a lot to do with it also. If you think about what the wind does to mountains, over time, it can shape mountains. What is the air?
Wow, this is really nice.
What is the air going in through your nose doing to your skeletal structure? Because it's a lot softer than the mountains and the rocks, right? So if the wind can do that, can you imagine breathing incorrectly and breathing a lot faster than you're supposed to, a lot more shallow than you're supposed to? Over time, it does impact your structure.
So there's one interesting point. If you look about this, we mentioned the resting posture. So we talk maybe for 3, 4, 5 hours in a day. We eat for 2 hours in a day. So that leaves us probably with 16 to 14 hours where we are at rest. So I think if we think about from a time perspective, most of our time in a day, we are at rest where these muscle structures could have impact on our teeth. And orthodontically, when I talk to patients, they generally come for teeth, they are crowded. And then when I tell them actually your teeth are only a symptom of a problem that is persisting there, they first of all are a bit apprehensive, but then you go a bit deeper into the topic and you talk about what you just slightly touch base on. But for me, the big question is, and I hope you can help me with, when would you say does it start the shaping in the wrong direction, and why?
In the womb.
Explain.
Lack of oxygen. So The mom, of course, the mom's body is producing that beautiful baby. If the mom already has a problem breathing well and breathing through the nose, the mom is always going to get the oxygen first, and whatever is left over is going to go to the baby. So if the mom is already a mouth breather or is not, breathing correctly, then we're already going to have an issue going with the air, enough oxygen going to the baby. Of course, there are different and other things that will affect the growth of the fetus. We all know that alcohol is bad, the cigarettes are bad. So there are plenty of things out there that could either benefit or not the growth of the fetus. However, if the mom is not breathing, we know that that could be a problem. Oh my goodness, there's so much we see in the womb. So babies are supposed to suck their thumb in the womb. We already see that. And that's a conversation I was having with Dr. Boyd. I don't know if you know Dr. Boyd.
David Boyd.
Yeah, it was a couple of weeks ago. I looked at him and I said, you know what? I was thinking about this. We see these babies suck the thumb in the womb. We don't know how often they do it. We don't know. We know they all do and they're supposed to. But what if that actually helped them develop? You know what? What if that was something positive in the womb? Because after babies are born and they're sucking their thumb, usually as a hygienist, I'm like, oh my goodness, that's awful. Take it out and give a pacifier. It's easier to remove the pacifier later. However, now in the airway as a myofunctional therapist, I'm like, no, babies are supposed to suck their thumb. So let's leave that there. It's more natural. It's, from your body. We're not introducing something artificial in there. And from what I've learned, as if a child is being breastfed on demand and you let that be, a lot of times if they don't have an airway issue, eventually they just stop on their own. So I'm not worried about thumb sucking. What else can happen early in life? Usually when a baby is born, they are already born underdeveloped. Most babies are born with the mandible, the lower jaw slightly too far back. We have seen whenever they get a tongue tie release, slowly the jaw comes forward a little bit. So usually these babies are, crunched up inside the womb. They have no room to move. So we also see issues when their whole body muscles, torticollis, issues moving very well because they've been inside this small confinement space, and what do we do? What do we learn? We learn to swaddle babies. It is wrong. We should not be swaddling babies. Please stop. Everybody stop swallowing your babies because they need movement. They need massage. They need those muscles to move and to work. And if you talk to an occupational therapist, they're going to tell you how important it is to get those muscle moving and those muscles moving, and also for reflex integration, they have to be able to feel things, in the real world. So there are so many factors, so many things that start way when the mom is pregnant that could impact the growth of the upper and the lower jaw. So starting with mom's breathing, and then lack of breastfeeding, and then lack of hard chewing and mouth breathing.
So you mentioned 2 points which are interesting. Number one, sucking thumb. My opinion on that is like there's a lot of nerve endings actually ending in the palate. And the palate is a soothing spot for a lot of children. So actually what you mentioned is this thumb sucking could be number one as a stimulus for growth of the maxilla in the womb. But number two is also soothing for the child in the womb. And then you just briefly touch base on this tongue tie, which is something in the media, sometimes it's a bit controversially discussed as a money-making machine and over-treatment and everything. But if you could just explain, what would you say you need to check on children with tongue tie? Because there are so many parents, they're saying to me, oh yeah, my child had a tongue tie. It has been released, but I can clearly see there's still a problem. So what do parents need to look out for when it comes to tongue tie?
The first thing that we have to know about tongue ties is that it's nothing new. back in the day, there are books that talk about midwives. They used to have a very long pinky fingernail. As soon as the babies were born, they would go underneath the tongue and cut the frenum. Because back then, they didn't have bottles, they didn't have formula. So if the babies could not breastfeed, they would die. So it's something they've always done. And then, of course, after World War II, formula came out, Gerber came out, all these extra things for, they offered nutrition for the babies. That's when everybody started recommending other options. And the tongue tie release kind of lost, its place in our field. And now it's coming back. Do we have more tongue ties? Maybe. There are certain people out there talking about the amount of folic acid. So everybody has the same amount of folic acid. Well, some moms are bigger than others. Should we be giving everybody the same amount? We don't know exactly why. But maybe, we're just recognizing way more now. I do believe that after the pandemic, a lot of things changed where people became, their own advocates, and they're looking for ways to do things more naturally, including breastfeeding. So the more moms that are looking to breastfeed, the more we're going to find issues with breastfeeding, and tongue ties just happen to be one of them. However, like my friend Jennifer Tell says, tongue ties are not a procedure. It's a process. Just getting the release done is not going to fix everything, because like I mentioned earlier, these babies are being born and they were just confined in this tight environment. We have to address the whole body. So just like an adult with a tongue tie, that we're not just going to go and release and expect all these benefits. We have to look at everything. So as soon as your baby is born, and even before your baby is born, my big recommendation is to go ahead and find an IBCLC, which is an international board certified lactation consultant, and somebody who's well versed in ties, because they don't have this training in their program either. Ask questions, we're not all born knowing how to breastfeed. It's a learned skill. So go ahead and find a professional who can kind of guide you. Okay, what should I expect when I have my baby? Is pain normal? What am I supposed to feel? Ask questions. And go ahead and have an appointment set up after the baby is here. A body worker or a body professional is another key component. So somebody who's going to give you, massage and exercises for the whole body, because sometimes just a baby having torticollis or just a baby being super tight could give you symptoms of a tongue tie. And then you release the tie and you don't see any benefits, or you see benefits for a little bit and then it comes back because the rest was not addressed. There's an IBCLC from Texas that I interviewed one day, and she was wonderful. Jewel is her last name. And she explained how they go with the process of releasing a baby's tongue. They treat the whole family, because it's going to take the whole family, everybody's help, in order to get that baby to a place where they're, doing well with breastfeeding. They got to make sure the mom is on board, the dad is on board, whoever else caretaker is on board. They explain how the stretches are going to be like. You have to make sure it's not going to reattach. A baby can't do exercises, so you have to do a lot of manual stretches. And I tell everybody, reattachment is healing. Everybody reattaches. It's normal. However, some people create scar tissue. That's the problem. Scar tissue is tight, and sometimes even tighter than it was before. And of course, what degree of reattachment you're going to have. So we need to help these babies, more manual work. A lot of dental hygienists like myself don't treat babies. However, if they have training in IBCLC or lactation consultant, then they can do the pre and post frenectomy work with these babies. So parents not only look for symptoms of a tongue tie, but also work with a body professional that can address other areas of tightness. Craniosacral therapy is a great thing to also do with these tight babies.
So basically, I was always the opinion that below the age of 4, in kids, you just release the tongue tie, let them go. Like a lot of industry where they release tongue ties in babies, They see them for one appointment and cut the tongue tie, say, see you later, because there's no myofunctional therapy needed. But what you just actually said is it's the opposite. Even kids under the age of 4 would need some kind of stimulus and therapy with massaging to avoid scar tissue under the tongue. So when is it for you, where would you say as myofunctional therapist, is it safe for you to start working with a child?
Hi, I hope you're enjoying our straight talk so far. If you're interested in any mentoring or one-on-one session with me to discuss cases or any questions you might have about the treatments of your patients, please reach out to us in our mentor program. We're offering that. We have more information. It's on our website, theorthodonticspecialist.co.uk. And now we're going back to our podcast. Bye.
So in the United States, it's a little bit different than everywhere else in the world whenever it comes to myofunctional therapy, because here we're mainly speech pathologists and dental hygienists that are working as myofunctional therapists with this treatment modality. However, what allows us to go into this training is not our license, it's our education. So my license as a dental hygienist is for me to clean teeth, not to do myofunctional therapy, because the dental board has no idea what myofunctional therapy is and how to, test me to make sure I'll be a good myofunctional therapist. So I want to make that clear. Dental hygienists can, in fact, work with young children, very young children. Whenever you're practicing myofunctional therapy, my training is from Brazil. Over there, there's only speech pathologists that teach you. So whenever they do myofunctional therapy with young children, it's just like myofunctional therapy with other kids. However, they need more hands-on work. So they need a little bit more help. So it's a lot more games and a lot more fun. And they will do a lot of manual therapy. So massages, kind of like myofascial release, do lymphatic drainage. They do a little bit more, hands-on work with these little kids. But you have to have the training. In the United States, that hands-on part is called oromotor therapy. And the speech pathologists separate that from myofunctional therapy. That's why it's believed that oromotor therapy can only be practiced by speech and occupational therapists. It's a gray area. Not sure if I needed to go there to explain these things. However, yes, even dental hygienists, myofunctional therapists can treat younger children. It looks a little bit different than regular myofunctional therapy, because most myofunctional therapists, what they are learning, it is exercises that you have to copy me. Okay, so if I do this, can you copy exactly what I'm doing? And a younger child can't really. So then, it's believed that it's not true myo, but from my training, it is. It's just a little bit different because my goals are the same. I'm trying to get, these muscles to move and these muscles to work out and to increase more oxygenation and, for them to have more tone and more control. There are just different approaches that I have to have with young children. So especially for pre and post-op release, definitely dental hygienist, myofunctional therapist is well trained in guiding a patient and a parent with the pre and post tongue tie release or lip tie release for a young child.
So to diagnose a tongue tie and especially give the referral for tongue tie release, would you say it should come from orthodontist, or should it come from myofunctional therapist, or should it come from both parties at the same time? What would be your idea about that?
Any age?
Let's say from 4 onwards.
Okay. I believe that it needs to be a decision that is made together. Of course, my functional therapist cannot diagnose, only the doctor can diagnose. However, I'm able to evaluate the compensations that are happening because of the restriction. So if I see a patient and let's call TRMR, they're grade 2 tongue tie. And I'm asking them to do certain things, I'm checking for tongue mobility, I'm checking for the suction. And I noticed that this patient cannot perform, for example, tongue lateralization, where the tongue goes side to side very well. because of this restriction. So what I'm going to do first, I'm going to write a report and I'm going to tell you, I noticed that this patient has, there it goes. I noticed that this patient has a restriction, is a grade 2 restriction. However, we're going to try some therapy first. Why? Because a lot of times stretching these muscles, the muscles around the frenum never stretches because it's connective tissue. But stretching the muscles around the frenum, sometimes we have to adjust the structure. Maybe they have, they need expansion. Just those things, and then addressing the whole body, sending them to a body professional that can address other body tightness that could be affecting the tongue also. We see an improvement in symptoms and we see an improvement in tongue posture. Then do we really need a release? So maybe not. So whenever I'm seeing a patient, I'm evaluating the compensations that this restriction is causing. After doing some therapy, it's going to become clear to me if I would recommend a release or not. However, I come to the release provider and then I'll ask, these are the things that I see. What do you think? It's ultimately is not my decision, of course.
So where in this decision making is an ENT? Would you also involve an ENT in that decision?
It's usually the release provider and the myofunctional therapist and the patient.
Fine. And also, I have a question like, how much would you say can myofunctional therapy perform orthodontic treatment, or where's the limitation? Because like when you do, for example, as a provider, myobrace, classic example, you say you are a myobrace provider, and then you might see patients who expect that by you giving them a device, that everything will be corrected, including crossbite, bone structure, and everything else. So what is your idea about? Because it frustrates, because people need to understand what does myobrace do, what does myofunctional therapy do, what does an orthodontist do? So how do you feel about that?
At least in the United States, I cannot dispense myobrace devices. Might be different in the UK. I can purchase them as a dental hygienist under a dentist, or as a myofunctional therapist under a dentist, but I do not know how to measure and how to diagnose to choose a proper myobrace device. However, they do have some habit correctors, and all of these companies do, including Myomunchi. So they do have these appliances that are a little bit softer, that promote the tongue going to the right place, promote lip closure, promote nasal breathing. Those appliances I can dispense. They also have some appliances that are helpful for the lips, for you to work on lips. So I can do those. However, the stage 1, stage 2, stage 3, we're not allowed to do. Dentist only. I'll refer to the dentist. Yes, 100%.
But now we have a problem, because how many orthodontists or dentists in your area are giving children these devices?
Many.
Wow. Because in the UK, it's completely different. Number one, children from the age of 12 years old are being seen. So the age group below 12 is not being seen. They are being told there's nothing we can do for you. So this topic of myofunctional therapy, myobrace, is not even on the radar for most parents, even so that parents are concerned, looking out for help, and they are getting it. And now, for me as an orthodontist, my hands are a bit tied by my environment, because if I would go in now and would say I start expanding arches at the age of 2, 3, 4, I will be going on very thin ice, and I might break into the ice if I do that. So for me, that's why it's so important for me to talk to someone like you, because I need somebody like you in my team, because you can actually, in a very gentle approach with exercises, achieve a certain result, but that is what I want to know from you. What would you say when we have talked about crossbite, high palate, for example? What would you say could you achieve by myofunctional exercises alone?
Whoa. So it depends on the case. Because if this patient cannot breathe, nothing that I do is going to work.
So because I think of one kid now, 4 years old, high palate, crossbite, she has sleep apnea and she's already on a CPAP machine.
So for me, that's expansion immediately, tonsils and adenoids taken out.
So you say tonsils, adenoids taken out because you see the main reason for the sleep apnea is the adenoids and tonsils at this age, right?
Both transverse deficiency of the maxilla and tonsils or adenoids. I'm not sure. I haven't seen the patient, but there's something obstructing. There's something in the way. There's a few reasons why children's tonsils and adenoids can be enlarged. We don't really know exactly what causes every single child. Of course, we would just address that. So it could be allergies, it could be dairy, it could be sugar, it could be processed foods. And then Dr. Christian Guilleminault had a hypothesis back in the day in the 80s. He was talking about this in the 80s, that it could be just the transverse deficiency of the maxilla by itself could cause enlargement of tonsils and adenoids. And then, of course, Dr. Stanley Liu and Dr. Yoon did a study where they expanded these children with an RPE and their tonsils and adenoids shrunk. We see that, dentists that I work with see that often happening. Oh, yes. Somebody's saying that my voice is doubling. Let me see if I can mute myself here. There it goes. Let me know if you guys can hear me, because you're going to hear me from the computer over here on Instagram. So, of course, it's going to depend on the specific case, on the specific child. I am the patient's advocate. I am going to be there to guide the patient based on the experience, based on the cases that I've seen, based on the providers that I've worked with and what I've seen. Ultimately, it's a parent's decision, the doctor's decision. However, if a small child comes to me and they have sleep apnea, especially if they're on a CPAP, we got to act fast. So none of dysfunctional appliances, a myobrace would not work, or any of those other habit correctors, because this patient can't breathe. You can't force them. I can't force them to keep their tongue up because they can't breathe. So we have to address the structure immediately. Is that tonsils and adenoids? Not sure. Maybe they have a polyp in the nose. I don't know. Maybe they have a cyst. Maybe they have something else blocking their nasal passages. We have to find out why. So usually I send every patient to get a sleep study and a CBCT. So the CBCT is a 3D X-ray that's going to give us a really good image of the structures of, upper jaw, lower jaw, the airway volume back here, where the tongue position is. If there's anything in the nose, CMJ is going to give us a picture of everything structurally, and we can kind of see, our tonsils and adenoids, turbinates, anything swollen, deviated septum. Based on that, with the collaboration of our team, we can make a decision for that child. So if they have sleep apnea, we have to act fast, whatever it is. If it's tonsils, adenoids, that's going to be my first choice, of course, because that's the golden standard right now. However, we need to find orthodontists that are willing to get trained in seeing younger children, because traditional orthodontics, they don't teach you to see somebody under 12. So that is why I believe that pediatric dentists now are getting this training, because they are trained in treating younger children. And orthodontists do not want to touch a crying child. It's harder. How are you going to do the impression of that? Thankfully, now we have the scans that are much easier. So I feel like we're lacking in the orthodontic community the willingness to get extra training to learn how to see these younger children, and to look at these other devices. You know, how much is too much when you're expanding somebody? When can you do slower expansion versus rapid expansion? What even makes something a fast expansion? How many turns a week, you know? So those are things that we as a community need to talk, and we need to learn from people who are doing it and who are getting successful cases. Because all of those providers who are getting successful cases, they've had plenty of failures. And that's why they're succeeding right now. But we don't know. We have to ask them. We have to find out what they're doing.
Hi everyone, I hope you enjoy our straight talk. If you want to find out more information about the courses we're offering, they're available on our website, theorthodonticspecialist.co.uk, in our course section. And now we will continue with the podcast. Bye.
I agree with you, because like what I find really interesting, what my personal feeling is on this is, when I have a kid with a sleeping disorder and it's quite severe, I go quickly in. So I don't think twice of going rapid palatal expansion versus maybe performing something with an aligner and do a slow movement expansion, because the more severe the sleeping disorder, the more quickly I need to act in opening the palatal suture. So, but again, like for me, the biggest thing is the fear of the community around me that I might get attacked for actually doing this kind of procedure. Like I even struggle to say now, I do it now this week on a 4-year-old kid. Yeah, on the kid I just mentioned, because she literally doesn't sleep. She is on a machine. So my personal heart tells me, okay, I don't care. I need to do this, because I hope that combined with an ENT and all the other things we just mentioned, I'm pretty confident I could at least improve the situation of this child. And I couldn't agree more. Like, where I do courses, and I do orthodontic courses, but I do also courses for pediatric dentists. I get much better positive feedback from pediatric dentists, because they see it every day in their chair, but they have a problem. They refer on to an orthodontist and they're getting told there's nothing they can help you them with. So this is for me exactly the frustrating part, is there's so much need out there that we need, as educators, you and me, we need a joint venture and make these people where there is somebody you can do something. And if the orthodontist is not joining that journey together, we need to do it ourselves.
Yeah. And if a child is transverse efficiently or AP efficiently at 4, do you think they're going to be at 12? I've had an orthodontist tell me, I'm not touching your child with my daughter right now. I can do everything I need to do in 12 months. So come back. I'm like, I don't care about her teeth. I care about her breathing. What is an extra year of hypoxia going to do to her? It's 18% less oxygen that goes into the brain if they're mouth breathing at night. Why are we waiting?
And what was the response?
Right? Because they don't have the training. They don't know. It's, you know, I can't blame them completely, because that's what they were trained in. And they believe that they're going to have a beautiful smile afterwards. But if you don't know it, you're not going to see it. That's why we need to keep doing these talks and podcasts and lives, and get together, invite your community. Let's do a study club. You know, Area Circle helps you guys put study clubs together. You have to grow your local community. You have to find like-minded professionals to collaborate with, because we can't do what we are doing alone. And yes, there are plenty of people that are going to come and throw rocks because we're doing something different that they are not. And it is okay if you feel it in your heart that it's part of your purpose to help these children who are not breathing well, who are not learning well in school, who are being bullied, who feel awful, who are irritable, who have tantrums because they can't breathe. And you have the tools in your hand and you can do something about it. We can't be afraid of what everybody else is going to say, because it's going to come. You just have to be ready for it.
And I agree. And also, like in the UK, there is a famous blog, mainly managed by professors in the UK. And there was recently an article who compared a rapid maxillary expander compared to watchful waiting. And the conclusion was that there's no clear evidence that maxillary expansion is beneficial to just waiting it out. So, but the problem in general is what we mentioned at the beginning is it's so multifactorial that when you look at the studies that are being done, purely by expanding a bone structure, yes, might not help the child in the breathing, but we need to have a multidisciplinary approach, and then eventually we could start a research study on it. But all the research that is out there is not being done like this. So we cannot go there and say, oh, wait, watchful waiting is the same as widening a palate. And also, we have to ask about the ethical responsibility we have. Who is responsible for this child? You just said couldn't breathe properly for another 6-7 years, and now they're struggling at school, can't concentrate, ADHD, anxiety, and all of these other issues which may eventually can be linked. We have to be careful what we say.
Yeah.
To the breathing. So who is responsible for these things later?
100%. Hypoxia is brain damage, everybody. It's damage. What are you going to do afterwards, after it's all said and done? But the more these professionals hear our call, and I feel like it really takes a personal experience. So having a child or having a grandchild with an airway issue, or not being able to breastfeed, or tongue tie, or CPAP machine if they have apnea, it usually takes something personal for these professionals to go like, whoa, there's so much more out there. And then they can go research, because they are so busy as it is. I know that around me over here, it's difficult to get an appointment with an orthodontist. They're so busy and they're so successful and they're making plenty of money. Why are they going to change what they're doing? They're going to have to slow down. They're going to have to make a little bit less money in the beginning until they can figure things out. But, looking at airway, it is more complex. It is more comprehensive. It is more taking a step back, waiting for myofunctional therapy to be done, working with myofunctional therapy. It's a little bit harder for professionals to understand everything that goes into what we do and working in a team.
I want to share something from my personal experience. Like, I moved to London 9 years ago. And when I moved to London from Switzerland, where I treated mainly kids, I treated only adults. I treated them with lingual braces, and the market in London is very competitive, everyone doing the same. So, but then you deal with adults all the time. And treating adults, you sometimes deal with the psychology of the adults as well, which you as an orthodontist, you can't treat. But financial interest aside, as an orthodontist, me focusing on prevention and children changed my life to a positive massively, because when you have this impact on a child's life and you make the changes in their life, you help them breathing, getting confident, and getting the love from them when you change their life, it's so much more rewarding than any dollar you ever made in an adult. And if an orthodontist is purely financially driven to make money, everyone needs to earn a living. That's absolutely fine. But for me, helping children gives me so much more value to my life that I can't even put any value of money on it. And this is what people need. And the reason why I do all these podcasts and these teaching and education is I realize the need is so big that we can't do it alone. We have to spread this word. We need to educate other people, because the need is so high that these children are crying out for help. But I want to give you one example. I want your opinion on that. I recently had a 45-year-old gentleman in the chair, and he came for a consultation. And the first thing he said to me is, "Can I record this consultation?" Which I already find bizarre in an adult, because you have to be careful nowadays. But anyway, he had a class 3 malocclusion, like the lower jaw was overdeveloped. So I looked in his mouth, I immediately spotted a severe anterior tongue tie.
I already knew it.
So you know it, because you know already the impact a tongue tie has on jaw development. But then when you looked at the medical history, this gentleman was on ADHD medication, was on antidepressants,
Mhm.
and he was an alcoholic.
Wow.
So he was drinking every night so he can get some sleep. So when I basically mentioned that his problem are actually not his teeth, the problem is the way he's breathing at night and the way impact it has on his health, this gentleman became very emotional because for the last probably 40 years, he's seen professionals all over the world, and
Mhm.
not one of the professionals ever linked his tongue tie to the way he is feeling. So what is your experience there? What would you say to that? Am I right to think that this is linked?
100%, 100%. It's all about development. We already know that if you plug the nose of monkeys, that their teeth get crooked. And then if you open the noses up, they start getting straight again. We know that lack of nasal breathing causes malocclusion.
And
The
how do you
tongue.
think about the mental health side of things? What is it?
Oh my gosh, like I said, it's hypoxia, it's brain damage. If you have a lack of oxygen to the brain, what do you think is going to happen? I have somebody really, really close to me who had dyslexia growing up, but she had, buck teeth. She was overweight, just this, young child and teenager full of bullying and tons of issues in school. Even though she tried hard, it was difficult for her, several other issues. And then finally, when she was a young teenager, they did braces, and then beautiful wide smile. She lost weight because then because you're able to breathe well at night. She no longer has dyslexia. There's no issues. Why do we have to wait for this child to go through elementary school, middle school with these issues? And what are the long-term consequences of that on a 40-year-old adult who has spent so many years not breathing correctly? We also know the lack of deep sleep is now connected with Alzheimer's disease. If you're not getting enough deep sleep, you're not getting the lymphatic system to work in the brain that clears all of the debris that accumulates throughout the day. What is that happening? Increases beta amyloid and tau protein in the brain, which is directly linked to Alzheimer's. There's 100% a connection, 100% a connection, and it's all about, it starts with breathing. It's the first thing we do whenever we're born, the last thing we do before we die. We have to address breathing first.
So I want to ask you a personal question. I know your intermolar distance was 30.4 millimeter.
You remember?
And you had palatal expansion by my dear friend Ilya Lipkin.
Mm-hmm.
How do you feel? What would you say from personal experience changed for you?
Oh my goodness. So I was an airway kid, and that's why I'm so passionate about this. I was bullied in school. My nose was running constantly, allergic rhinitis. I couldn't breathe well. I needed to sleep with two big pillows in order to be able to breathe a little bit. I slept with my mouth open. I snored. I drooled. I never had a sleep study as a child. I bet I had some form of sleep disorder breathing. And as I got older and I was introduced into this field, I did myofunctional therapy on myself for a while, and just myofunctional therapy by itself did help me sleep with my mouth closed, breathe through my nose. So it did reduce, brain fog. It did reduce irritability. I still have a hard time, or had a hard time, working out. I couldn't run because I couldn't get enough airflow in my nose. Allergies were still kind of bad. And then I had palatal expansion. And I remember when my nose all of a sudden opened up and I could take a full breath in without effort. Working out became so much easier. Clear thoughts became so much better. Sleep is more deeply now. If I have a good night of sleep, I go to sleep and I wake up and it's like nothing happened. I don't wake up throughout the night anymore. And I used to very, very often. I also used to have insomnia. None of that. Nasal breathing is undervalued. I wish that we talked a little bit more about it. But now also I have more room for my tongue. I still have the appliance in my mouth. It's called a MARPE, M-A-R-P-E, mini implant assisted rapid palatal expansion. I have 6 screws for those who want to know. A lot of times for my age, 4 is not enough. I did not have a piezo cut. So it was just the device, and in 3 days, turning about twice a day, I split. The suture split. I had a light headache, didn't have pain at all the whole process. I'm seeing him next week again to find out where we're gonna go now. But it's one of the best things that I have ever done for my health, not only now, but for the future. You know, my father has full-blown sleep apnea. My structure is very much like his, or was. You know, I'm changing. My nose is so much wider now. My upper lip looks better. Everything has changed. My cheekbones are so much higher, but I feel better. I like the way that I look. I used to hate my side profile because I am retruded. Top and lower jaw are too far back. I do have a huge bump on my nose. Why do people have bumps on their nose and other people don't? Could that be related to a small maxilla and not having enough room? I don't know. But these are questions that we have to ask. So even my nose looks better. The tip of my nose went up after my expansion. So not only looking at myself, my skin looks better because now I have more oxygen. It's insane. It has changed my whole life. I cannot wait to get it out to really feel what that tongue space feels like now.
So you had the luxury, obviously, that the orthodontist as a kid didn't take 4 teeth out, right?
Thank goodness. So I always had straight teeth, beautiful straight teeth, but very narrow and very high vaulted palate. Very high. So whenever I was 14, I begged my mom to take me to the orthodontist because I thought it was cool to have braces. And they gave me a palatal expander. And it made me talk super funny. And I had, you know, the little wire on the top. Oh, I felt like I was the coolest kid ever. I loved it. And that's when I moved to the United States and I forgot my expander in Brazil. So I remember going back 6 months later and it didn't fit anymore. So I know I relapsed some. I don't think I fully relapsed because I remember there was this piece of candy that I could fit after I did my expansion and I couldn't fit before. So I was probably a 27, 28, I would guess, before. So it did change a little bit. And you know what? That time, my breathing got better. I started looking better right around the time during the expansion. So it already improved some. However, I didn't continue. I didn't do my functional therapy either. So I relapsed. And after, you know, all these years of learning more things about airway and going through the MARPE, I mean, we got to start early. We got to get, you know, start getting these kids because I know what I went through. And if I can't, you know, help any child not have to go through the bullying, the allergies, the not sleeping well, you know, studying super hard, but you still not making great grades in school because you can't breathe. You don't have the energy. You don't have the energy to play sports, to work out. It's not fun.
So when you have the device in your mouth now, and you are supposed to do myofunctional exercises, how would you say, can you do it? Should you wait until the device is out? What is now your personal feed? Because we're doing kids with these devices. I don't do so many adults because I like the kids too much. But to which degree can I tell kids now you should start already your exercises, or now you have it in your mouth? You are the best reference for me. What can kids do and what they can't do when their device is in?
So it depends on the issue. If a child has an overbite, they have reduced intraoral space. When they get an appliance in there, if you think about it, it's going to reduce the amount of room for the tongue even more. So a lot of times those children will have worse sleep until the appliance comes out. So we have to keep that in mind. However, myofunctional therapy is not only tongue position. Is tongue position the most important thing? Absolutely, because without the tongue position, you can't breathe, you can't keep your lips closed and all of that stuff. So as a myofunctional therapist, I'm also working on nasal breathing. I'm working on awareness. I am working on the cheeks, the lips, the oropharynx. There is a lot that I can do while they have the appliance in their mouth, increasing tone, increasing strength, I don't do chewing and swallowing until they're completely done, until after expansion, after tongue tie release, because why am I going to train somebody to swallow a certain way if as soon as the structure changes, the function changes? This is very important for people to understand. The function is always going to follow the form. So depending on what the structure looks like, your body is always going to compensate and find a way to do function, because we have to function, right? We have to swallow, we have to chew, we have to breathe. But it's my turn as a myofunctional therapist to check to see how that function is working and if I can do anything to help improve based on the structure of the patient. So yes, 100%, there's plenty that they can do with myofunctional therapy. A lot of times I will see these patients once a month while they're going through expansion. So if it's a 6-month, 8-month process, sometimes a year, I'm still keeping up with them. And I'm not giving them major things to do, but I'm giving them 1 or 2 exercises to do during that time. So they get used to me, and there's so much already that we can do with those muscles. And that by itself makes a big difference already.
So in your experience, what is the best friend for you in terms of palatal expansion when you see orthodontic patients? What is for you the best expansion device as a myofunctional therapist?
Not everybody agrees with me. I am a lover of an RPE. There are several different types out there that you can use. Recently, I heard the Hyrax is not great. I've always liked the appliances that have the acrylic up there, because I feel like it gives a little bit more support to the palate. However, I am not an orthodontist. I don't know exactly how things work in your world. I do like them fixed better than removable. I feel like it's easier. You don't have a choice. You got to keep it in there. At the same time, you have to make sure that the child is okay, sensory wise, to having something in their mouth. So a lot of times we have to desensitize a patient before they can allow an appliance in there. I also like the fixed appliances because they tend to be a little bit more rigid. So I feel like putting more pressure and making sure that suture is going to open a little bit more than a removable appliance. My child has had 3, Zoe has had 3 different appliances, and she's lost all 3. So 100% fixed. Oh, something I forgot to say about MARPI in adults and myofunctional therapy. Very important to do myofunctional therapy whenever you're doing palatal expansion as an adult, whenever you're working with something like the MARPI, because when the suture splits, everything is a little unstable there. If you're a patient that's used to eating on the right side only, let's say, and all of a sudden everything is a little unstable and kind of growing, it's going to get worse. So a myofunctional therapist will be able to tell you chew more on this side while you're going through the expansion. Let's work on this side a lot more to see if we can kind of help a little tiny bit with the asymmetries. We're all asymmetrical. There's barely anybody out in the world that's perfect, okay? Your left and right side. So those asymmetries are always going to get worse, especially in adults, and especially if they don't have any myofunctional therapy work as they're going through that expansion process.
So if I would say to you that the new Invisalign palatal expansion device that is already launched in the US and Canada is not your best friend.
Which one is that? The Invisalign? So I recently, last week, had 2 patients, they're siblings, and the boy doesn't have a lot of crowding. The girl has a lot of crowding, and they are, 13, 10, 13, 16, 15, around the age, 10 to 15 years old. No, 13 to 15 years old. I want to get something in there fast, and I want to get something in there to open that suture, especially with the girl that's so crowded. And with him because he has sleep issues. So everybody's a different case. You would look at one person, looks like they're going to have a worse airway. It was the other way around for us with these patients. So immediately the orthodontist said MARPI, and I was like, hell yeah, let's do MARPI. But they didn't agree. So she offered the other option, which was the
IP.
Yes. And immediately I'm like, what? That just came out like last week. No, we do not have enough studies. We do not have enough, it's going to be probably, tooth tipping, like we can't do it. And then, of course, I got in touch with the orthodontist. I was like, what's going on? These patients really need, something aggressive. And she explained that the patients didn't want to do it, was their choice, and that she was one of the trials for the IEP. She did it for 2 years, and she did see plenty of sutures open up. They have CBCTs and everything. So I asked her to send me some of that info, and it makes me super happy and comfortable knowing that she has already used it for 2 years. She has seen plenty of patients. Of course, I want to know the age of those patients. I want to know the symptoms of those patients. I want to know the tongue position of those patients. I want to know if the palate is going to hurt. Like, I don't really know how tight it is, how close it is. I don't have enough info, but I have 2 patients right now that are about to go through it. So I will let you know in 5 to 6 months how everything is going with that.
I think the biggest component for me as an orthodontist is the compliance point of view, because obviously when we treat children, we have only limited time as orthodontists where we have a compliant child. And in that time we need to achieve the maximum outcome. And when we have, in terms of airway, when it's an absolute need and urgency, my personal opinion is we cannot trust a child to do the job for us with none of the research present right now. And so I'm also still on the fence with this device because it's removable. I agree with you. I prefer a fixed device for that, because on the 4-year-old girl I'm just treating, I would never ever consider a removable device because I need to be quick.
Mm-hmm.
So, and I know which orthodontist you're speaking to. So, so that's, we need to be a bit critical and have a look what's the age group, because we don't know yet. And certainly when we talk about teenagers, it's a different ball game anyway. So it's interesting. Is it the future? I'm not sure. It's to be found out. But the thing is, from a company perspective, we need to have also a company who focus on the children's side as well. And a company you're talking about is mainly focused on adult treatment. So as an orthodontist who is focused on prevention, it's sometimes questionable, is it the right approach or is it another thing time being? So what I do nowadays a lot is I combine metal printing device like armies with an aligner on top of it. So because I can maintain the bone structure while I still align the teeth. So that is something which I find works really well. And it's super important. So at the end, do you have any questions you always wanted to ask an orthodontist at your disposal that you don't know the answer to?
My friend Sam over here just mentioned awareness of AP. I think that all of us are very aware of transverse deficiency, but we don't talk enough about AP deficiency, what to do, when to treat, what do we do with the mandible? How do you bring the mandible forward and address the TMJ at the same time? I'm not an orthodontist. I don't understand enough about that. And usually when I meet a new orthodontist that I'm trying to get them, into our airway world to help me with these patients because I don't have anybody else around, those are usually the questions that they ask me. Well, if they're not a class 3, why am I going to bring the maxilla forward?
So basically, like, we know that the reason for deficient lower jaw is quite frequently the deficient upper jaw. So that the lower jaw is trapped. Like when I do my consultation, I always compare it with high heels of ladies.
I love that.
They have these beautiful high heels on, and the foot will never be able to slide forward. So what I see, because we see that in adults as well, in adults, John Kreuzensäcker will call it constricted envelope of function. So the upper jaw is trapping the lower jaw, and as soon as you release the upper jaw, the lower jaw naturally will posture more forward.
Until what age?
Well, at any age, because in adults you see destruction. You see
Okay.
wear on front teeth, you see open bites, and so on. But that's a completely different topic. This is John
Yes.
Coy's functional. So in children, when you give them the platform early in life, like a wide upper jaw, the lower jaw has a lot of potential to grow naturally forward. When the jaw is trapped, it will never do that. So, and then it's super important when we look at growth itself. The lower jaw has its main growth at growth peak in puberty. That's true. But before that growth peak, we have tiny little waves of growth of the lower jaw. And that starts is at 5 to 9, 10. We have tiny little waves of growth. And that these small little waves we should encourage to use to bring the jaw forward. So when we do early interceptive orthodontics, I use a lot of advancement devices like mandibular advancement, or Angel Liner will call it A6. So it's a twin block device that brings the jaw forward while you're widening the structure of the upper jaw. So it's super important. And actually, I'll give you one example just now, today. I had a kid, I widened the upper jaw. It's a complete lower deficient jaw. And I gave her class 2 elastics at the age of 8. She was so compliant that she came in a class 3.
Wow.
So I actually got scared to think, oh my goodness, from an overjet of 7, 8 millimeter
Oh,
to
wow.
a negative overjet, where I had said, oh, we have to stop. You know, and it of course relapsed a bit, so it was no problem. But
Yes.
I document that case because what I try to say with that is the earlier we start developing arches and bringing lower jaw forward, the more we will get the airway open up. We're not creating these class 4 cases David Boyd is talking about. Yeah, we bring the A and B point, we call them, in forward. So the lower jaw is important. We catch it just as early as we do the upper jaw. But the upper jaw, we know the palatal suture is fusing a bit earlier than the lower jaw. And also what people forget is everyone's talking about treatment of teenagers. But you cannot bring a jaw forward in teenagers. They're maybe not growing so much anymore, or they're not wearing the device as instructed because they are full of hormones. They do whatever they want to do at that time. So it's a time period which is really hard for an orthodontist to have control over a patient. Versus young children below 10, they're super keen, especially when they're getting bullied because of protruding teeth. So this girl I was just talking about, she was so concerned about her appearance that she did exactly what I wanted to do. And she did it so well that I got scared because it went the opposite direction. So again, it's super important to get in early rather than late in developing the jaw upper in the transverse, but sometimes AP. And to finish that off, when I like face masks, yeah, like rapid maxillary expander with face mask in combination or grommets mask. The younger the children, the quicker we have this corrected. And in speed, I mean weeks. So it's so powerful that within a few weeks of wearing a mask, you can completely change their whole profile. And when you see that, and you see that what it does to a child, you get emotional. And I get sometimes messages from the mom saying, my child looks so different. You know, like you mentioned yourself, the cheekbones getting high, the skin getting more oxygen. And you see in their eyes, they're more shiny, more spark in their eyes. Their whole personality changes, their behavior changes. And there's not just teeth, there's so much more that changes in these young growing children. So we need to intercept early. And you know so much, and you unfortunately you can't do it. You need orthodontists, which I'm happy to help with, to be able to do this early. And on a professional side as well, with prevention, you can just as much run a business that you can do on adults. Because
Yes.
when I did my business, started my business 2.5 years ago, we only focus on children. The whole
Mhm.
marketing was for children. And now we are growing so quickly that we can't even keep up with getting new stuff in because we have too much demand. So if you think there's no business in children, you're wrong.
Mhm.
And the beauty of it is a beautiful business because you help children every day and you can then choose if you want to treat the parents or if you don't want to treat the parents.
Mhm.
So, but this AP correction, I totally agree. And hopefully in the future, what I want from companies is, yes, we have now with Invisalign a brand that gives us the transverse correction, but it will not give us the AP correction.
Mhm.
So hopefully in future, we will have companies who give us both.
Yes.
That's my
100%.
wish.
Yes, I love it. I love it. And together we can keep working, keep treating, keep finding out, better ways of doing things, what works, what does not work. So spaces like this are very, very important for us all to grow. So thank you. Thank you for having me and inviting me to chat
Thank you,
today.
Rena. It was amazing. And it's so nice to have your vibe and your smile. Your smile is amazing. I hope we could help to create more awareness of the importance of working together in a collaborative community. But it takes more than just the two of us, it takes a whole team.
Yes.
Thank you so much. Have a lovely day. Have a nice evening, everyone. And I hope we meet in Vienna latest in October.
Yes.
Have a nice evening.
Thank you.
Take care.